Excellent. Good morning, good evening, and good night, wherever you may be who are joining us. I'm Alison Hodak, the National Manager of the Clinical Programs for Organ and Tissue Donation and Transplantation in Australia. So we welcome you to the Commonwealth Tribute of Life webinar series. The topic today is going to be on donor coordinators. So this is the 10th webinar of the series. And we'll be focusing on the work that donor coordinators do and how we train them. So I'd like to welcome my co-chair, Olive McGowan, the Chief Nurse of the NHSBT, and also our speakers, Jill Featherstone, the National Professional Development Specialist Medical and Education Lead for the NHSBT from the UK, Pallaviv Kumar, the Executive Director of Mohan Foundation in India, and one of my own colleagues, Yoni Hope Hodgetts, Donor Specialist Coordinator from Australia. So to get started tonight, a quick reminder that you can put your question in the Q&A function there, and we'll convey these to the speakers at the end of the session. So I'm just going to hand over to Olive to welcome our first speaker.
Thank you very much, Alison. And as Alison has already said, welcome to everybody and thank you for joining. I am going to welcome our first speaker, Jill Featherstone, who is a colleague of my own. So welcome, Jill, and thank you very much for doing this session for us. Jill, as Alison has already mentioned, is one of our professional development specialist and is our medical education lead here at NHSBT. So she is very knowledgeable on all aspects of donor coordination. So I will now hand over to Jill. Thank you very much, Jill.
Thank you, Olive. As you've highlighted, my role is for medical education, but I'm very much ingrained in the specialist nurse education team as it is. I'm just going to switch my camera off just so I don't get distracted, and I'll share my screen. Hopefully, can somebody just confirm that you can see that?
All good. Thank you, Jill.
Thank you. So in the UK, we have our specialist nurses. We have a delineation. We have specialist nurses, specialist requesters, and you'll see what their different roles are as I go through the presentation. And as we've already highlighted, the focus here is on organ donation coordination, but as we've merged with tissue donation within the UK, we now see this as a whole donation focus now as we go forward. So just a bit of background to enable your understanding of how our structure supports our working. We are divided into 12 regional teams. The UK, of course, is of 4 nations: England, Scotland, which is in the pale blue at the top there, Wales in the turquoise at the bottom left, and Northern Ireland in the dark green. But these 12 regional teams each work autonomously, but are linked by common and aligned working practices. Each region has a regional manager and team managers to provide expertise, support and leadership for our specialist nurses. And the regional managers may cover more than one region. We have a 24-hour, 7-day-a-week service of donor coordination. But what the beauty of this flexible structure is that we can support across regions where there's differences in donation activity. It's not so frequent, but it does mean that we're very, very flexible in the way that we can support that activity. And it also means that then working with adjacent regions, each region can use that opportunity to participate in education and different getting together opportunities, really, I suppose, to challenge their practice and to extend their practice by learning from others. So in terms of thinking about the ethos behind our work, it's very much family focused. This is their experience, and we want to honour that and want it to be a positive, even though it might be at the worst time of their lives. And leave a long and lasting and positive legacy for that. Obviously, safety is a big thing, not just for donation practice, but of course leaving families safe in their decision support or not, and leaving them in a way that feels safe to them in their decision making. Obviously, we want it to be effective for donation, but also for those clinical teams and those relationships in doing that. We want it to be efficient as well. We know that everywhere in the world, ITU beds are precious, donations are precious, and we need to be able to respond to clinical demands as well as those that a family might seek. So efficiency is quite a focus for us. Along with communication. Communication is the grounding really of all of our work as a specialist nurse in the UK. This is Jackie. Jackie, like most specialist nurses, come from an intensive care background. There are three real areas of our role, I would suppose: hospital role, the on-call role, and our education and development. In terms of the hospital role, donation work still comes first and foremost. It might be that we're picking up from the clinical team that's a potential donor for that day, and we would start making some first line assessment before alerting a team or an on-call to attend. So some of that background and foundational work can be done. Part of the hospital role is engagement and building relationships with every area that might have dealings with any part of the donation process. That's not just the ITU teams, it's the laboratories, it's the mortuary, it's the theatres. It's really building those relationships to make it a strong and coherent approach to donation. Our specialist nurses collect data on every death in a critical care area to provide our audit and review. And this serves a multitude of purposes, not just the data output itself, but it feeds into our reviews on how we inform our practice, how we respond to things, and really challenge what we're actually doing. Does it actually work? Is the data there to prove it? And along with that hospital role is teaching, working with our clinical lead for organ donation within the hospital. It's important that we engage and educate those involved where donation happens, again, building those relationships and so that they can have confidence in supporting good donation practice. And that's a big part of that hospital role. In addition to that, every hospital has a committee that scrutinises the effectiveness of donation in the hospital, and the specialist nurses contribute to that work. So that might be some of it as promotional work, but it might also be some targeted work. For example, if you hadn't had a donor for a little while and theatres were feeling unfamiliar, so you might do some targeted work with theatres. And overall, that hospital work is crucial to maintaining the effective and efficient system and good relationships. And we understood that much more when COVID came, because we couldn't be in the hospitals, and donation familiarity and practice familiarity didn't maintain. And so we know now that we are going back to basics to support that much more. In terms of on-call, this is about 30% of a working week for a specialist nurse, and I've outlined how our facilitation occurs, and it's a bit busy, I grant you, but it just shows you here, I don't know if you can see on my pointer, we've got notifications at the start of the process, and that might come as a phone call to the central hub, or it might come in person on the units. And all of that starts with initial triage and assessment of suitability. From that, we might be looking then at gathering some history, some whole health history, looking at what information we have on this donor. And then we would be looking at family focus. This is a big focus of our work and working with families. It's about planning those conversations before we go into the room so that they're effective and efficient when we're there, that the family feels supported in our understanding of them, and that we start to explore with them their understanding and the discussions that they want to have, and exploring any uncertainty they may have around it. Coming back then to that schematic view, if neurological death testing is involved, we will be supporting a family through that. We can look at making that much more efficient as well by supporting an efficient and rigorous preparation towards testing with those early notifications. And we can support nursing staff and their awareness and responsibilities, particularly when we've had a big throughput of new staff in the critical care areas. It means that we can reduce delays and for families and clinical teams. We would also support families if they wanted to witness those tests, to help with their understanding and working through with them so that they felt fully prepared for what's happening with their relative. We can also be there as specialist nurses to enable clarifications around testing for clinicians who've not done this in a little while. It might be that they need to access expert guidance, and we can certainly be that first port of call, but then we can escalate that should there be uncertainties around the testing to more expert people. And it means that then once we understand that this is a potential donor, we can introduce those known bits of care that we know benefit good donation practice. Alongside that, so we'd be using our specialist nurse in the hospital as well, in addition, to help gather that information and be looking towards that optimisation of a donor. And we work collaboratively with the clinical team to enable the donation to be of the highest possible quality. And we have more and more training in this now. The specialist nurses are really wanting to gain confidence in this and develop their expertise in this. Many have a good deal of that, but we're certainly trying to standardise the approach that we're doing. And it means that as specialist nurses, we can guide any investigations and interventions whilst liaising with the transplant teams. And then, of course, once we've registered with our national hub, we're finding recipients through them. We're liaising with the retrieval teams. We're then preparing for theatre and that transition. And again, this is collaboratively planned, coordinating to achieve an effective and efficient arrival at theatre with everything in place, balanced with the family's needs, and a real clear plan of what's going to happen and when. But all of this takes education, and there is a clear commitment to learning and education for our specialist nurses. Each regional team has a professional development specialist working with both trainees and established staff, and it encourages them to celebrate their role. And certainly at local, regional and national level, we would encourage them to engage with all sorts of opportunities and celebration of their role. Foundation training is of 20 weeks within a 6 months probationary period, the focus being on their independence on the rota, of course, but it's balanced between a collective learning nationally and local experience and teaching opportunities alongside competencies and workbooks and support mechanisms for that. For our established specialist nurses, we have annual mandatory updates based on what we've learned from the previous year, so that we're responding to the needs of this that the service is demanding. It's we certainly work on regular performance reviews, looking at the regional and national data. We have clinical supervision. We have one-to-ones with team managers to make sure our health and well-being is covered, and that we're managing in the role and that we're happy in the role, alongside an awful lot of shared practice, learning from one another's experiences and targeting that training and process delivery that has arisen from any governance reviews. And that is our experience in the UK.
Excellent. Thank you, Jill. That's really, really insightful. We've already got a couple of questions there, so we'll hold them till the end, and we'll move on to our next speaker, Yoni Hope Hodgetts. Yoni, I welcome. Yoni comes from a background of being a donor coordinator for probably about 10 years, and she's based in the central coast of New South Wales, and as she puts it, a bit beachy area, and so she's here to talk about donor coordinators in Australia. Thanks, Yoni.
Thank you so much. I'm just going to share my screen. Have you got that there? Yeah.
Yes, we do. Yeah.
So yeah, I'm going to talk a little bit about the organ and tissue donor. I'm just going to get rid of my face there. I'm sorry, it's just distracting me. I'm going to talk a little bit about organ and tissue donation and the two specialist roles that we have in New South Wales. I had a little sort of inner sort of smile when I saw your picture, Jill, of your regions, and I thought about New South Wales and the fact that we have such a tyranny of distance here. I've been to, like you, we're very flexible and we go to donation where it is and where it's needed. And if we need to work outside of somewhere that we would normally work to help out, then we do that. And for me, that's meant that I've been to Tweed Hospital and I've also been to Bega Hospital, and they are 1,300 kilometres apart. So there's a very, very vast distance between the bottom and the top of New South Wales. In terms of the nursing roles that we have, there are two in New South Wales. So we have the, oh, sorry, I'm just gonna, it's not popping across to my screen. Sorry about that. I'm a nurse donor specialist, not an IT specialist, I'm afraid. So in New South Wales, we have someone like myself. I'm a donation specialist nurse, and I'm based in our local hospital. So you'll generally find us based in the intensive care offices. We are in that area mostly because that's where our end-of-life referrals are from, and we wanted to be embedded in all end-of-life conversations. So the roles of both the donation specialist nurse, which is locally based, and the donation specialist coordinator, which you'll see on the right, these are both nursing positions and they're clinical nurse consultant positions. That means that we're heavily involved in a whole heap of domains that are education, research, quality assurance and programs, lots of data collection like you, Jill, and looking at what we're doing, how we can improve what's working and how we can tweak our service to meet the needs of both our intensive care community and also the patients and the families that we look after. We do a lot of planning and a lot of leadership within our hospital spaces. So for me, though, today I'm more talking about what we're each doing in terms of organ donation, referrals and donor coordination. So for me, locally based at Gosford Hospital, an hour north of Sydney, I'm wanting that I'm involved in all end-of-life conversations that occur in both our ICU and the emergency department. Historically, that's been patients that are going to be extubated, but we're really trying to embed ourselves in all end of life. And that's because while organ donation is not possible in all cases, oftentimes tissue donation is, and that's really important to families. So we're trying to make ourselves a part of that as much as we can. In terms of organ donor coordination, again, we're present for all family donation conversations. It's not always led by the donation specialist nurse. We're really trying to embed a collaborative approach to having conversations around organ donation. And that collaborative approach is quite planned, just as Jill described in the UK. And it will involve myself and the treating intensivist, the nurse that's looking after the patient, the social worker, and anyone that's important to that family being in that room to have that conversation. Donor assessment would include a full physical assessment of a consented donor. Again, we're looking through all of the medical history, gaining a good history from the family, which I quite like because I find that that's actually a period of time that I get to know the family better. I get to know the patient and how important they are to that family and the things that they would like to know for me to know about that patient. We are involved in the donor management. We work alongside our intensive care team and are there to assist them and follow the guidelines for good donor management that have been put out by our donation community. And a lot of that occurs in hospitals that see organ donation quite infrequently. So for some hospitals may see donation once or twice a year. If you look up to the middle, New South Wales has over 34 hospitals that we look after in our network. So the ability for some hospitals and their staff to be confident in donation just isn't there. So our role is really to be very supportive of those staff during donation and also in education so that they feel much less stressed in the moment. And a big part of my role for me is in family support and staff support during donation and after. The Donation Specialist Coordinator is based in Sydney. They are at the head office in Kogarah of the New South Wales Organ and Tissue Donation Service. And they sit in that office with our educators, with our Director of Nursing, Juliana Selsa, with our clinical manager, and with our state medical directors, and a whole host of staff that look after our community work and are incredible in terms of administration for us. In terms of what they're doing in donation, well, they are the eyes and ears of all referrals across New South Wales. They do all donation organ offering and they are on for coordination, much like us, 24/7 on a rotational basis, and they do a morning shift and a PM shift. Donation nurses that are in the local health district, like I am, we work only during the day and are then on an on-call rotation with nurses in nearby hospitals on a 24/7 basis as well. So during referrals, I would be consulting with my intensivist, where the Donation Specialist Coordinator is coordinating with the State Medical Director on cases that are a little bit more complex, and also with the transplant teams to sort out things like medical suitability and whether donation can proceed. They oversee the entire process of organ offering. So I will never speak to a transplant coordinator in the entire process of donation. My role is always just with that family, with the patient, and with the intensive care team and the theatres at my local hospital. In terms of the Donation Specialist Coordinator, there are 2 staff that are on during the day and the PM, and also then on call. One will do the donation coordination and the other will be on for retrieval. And that means that they will actually attend to the surgical case, wherever that may be, whether that's where I said in Tweed or whether it's in Bega. They will be flown to those more distant hospitals to support the theatre processes. They also organise all of the packaging and dispatch of organs to those transplant centres. That side of the donation process is not done by the local nurse at all. So I guess what I'm sort of working towards speaking about, and I'm really sorry, I'm from Australia. I know there are people in the audience from England that would understand the term the meat in the sandwich. For those of you that may not have heard this term before, it's about being someone that's in the middle of 2 people or 2 opposing sides. And I actually don't describe donation specialist nurses and transplant coordinators as being on opposing sides. It's just that we both are advocating for different people, and it's the Donation Specialist Coordinator acts like a conductor, and they are pulling the strings. They are the conduit of all information that occurs between the donation specialist nurse in the local health district to the coordinator. And I really like that system. I like it that my focus is on the patient and their family. That's who I advocate for. I'm advocating for really good transplant outcomes because that's what my family wants. And I'm there to ensure the dignity of the patient that I'm looking after in their end of life, to fulfill the wishes of that patient and their family, and to make sure that donation is considered every time that it's possible in my hospital. That's what I see as my focus and my role. I'm sure for a transplant coordinator, those pictures are enough to say that they are there advocating for their recipient. They're wanting to have excellent organ function for that person ongoing and good outcomes for their recipient. And I love it that we're both there advocating for our own, I guess, people that we're serving when we're working in donation and in transplant. In terms of the New South Wales donation specialist roles, we're working together. So the donation specialist nurse and the donation specialist coordinator, we work together. We're working very hard in New South Wales to increase organ and tissue donation. But I think our primary goal is just to provide excellent end-of-life care. And I think that if we do that every time, better donation rates and outcomes are only going to flow from there. Thank you.
Thank you very much, Yoni. That was fantastic. Thank you. I am now just going to introduce you to our next speaker. And our next speaker is Pallavi, who is the Executive Director of the Mohan Foundation. And she's going to talk to us today about the wonderful work that they're doing in the Mohan Foundation. And Pallavi is in a very hot India as we speak. She told us earlier on she is in an area with 47 or 48 degrees. So I'm going to hand over to her to tell us about the great work that's going on at the Mohan Foundation. Thank you.
Thanks, Olive. Thanks for having me here. Donor coordinators in India. In India, we use the term transplant coordinator. Not a great fan of that terminology. I just wish we had used something better when we were drafting the act. But transplant coordinators is what it is. And as per the law, defined as a person who's appointed by the hospital for coordinating all matters relating to the removal or transplantation of human organs and tissues. In the year 2011, so we passed our law in 1994, and in an amendment to the Act in 2011, it was made mandatory for hospitals to have transplant coordinators on their roll, even for them to apply for license. So that's the importance that was given to this person. And it was a lot of push by foundations like ours to say that, you cannot have a program without a counselor in place, without a person who will speak to families. The Act says who should be this transplant coordinator. It could be someone who's a graduate of any recognized system of medicine or nursing, or it could be someone with a bachelor's degree in any subject, but preferably a master's degree in social work, psychiatry, sociology, social sciences, public health. So that's really who it could be, who could take up transplant coordination with additional training on transplant coordination. Really,
Pallavi,
yeah?
sorry, just to interrupt you. Your slides aren't moving with your talk.
Are they not moving?
No.
No, we're still on the title one, Pallavi.
How does that happen? Let me just stop screen sharing and start again. It was moving earlier when we tried.
I was too busy listening to what you were saying to notice.
So, is this moving?
Yes.
All right. So like I said, transplant coordinator, that's the term we use, and that's the definition made mandatory by the Transplantation of Human Organs Act in an amendment in 2011. So you can't even apply for a license for transplantation unless you have a transplant coordinator on your roll. These were some of the qualifications that I was talking about. But really, what we advocate is that it should be a person who feels strongly for this kind of a work, has a bent of mind towards organ donation and helping families, and feels passionate about being someone who can make this marriage happen, of helping people who need transplants and working with families who can say yes. So because we feel that everything else can be taught, but this is something that you really cannot really explain. In terms of training, really Mohan Foundation started transplant coordination training in the year 2009. Before that, really nobody was doing any training for transplant coordinators in the country. And we started face-to-face training. And many years ago, we also started a one-year PG diploma in transplant coordination and grief counseling much before COVID happened. So we were fairly, geared up to deal with COVID lockdowns and lack of physical trainings. We have now subsequently also introduced a 1-month transplant coordination professional certificate. Surprisingly, even after the hiring of transplant coordinators was made mandatory in 2011, there was really no national body doing any training in transplant coordination. We have continued to take the lead. Now NATO is thinking of developing a program. More recently, we have also started coming up with master classes with more specific topics like the legal aspect. We just launched 2 courses, the legal aspects of organ donation and transplantation in India, and family counseling and conversation on organ donation. And we plan to create more such training modules, which are shorter for transplant coordinators who are already working in the field and would benefit with something specific and more focused. So like the rest of us, Yoni and Jill shared, typically a disease donation process can be divided into roughly these 7 steps. Where you identify a donor, you're declaring the death, you're obviously approaching the family with the purpose of getting a consent. There is assessment and management of donor, retrieving organs, and there's follow-up. Where does a transplant coordinator figure? Almost everywhere. So the responsibilities are numerous, almost never ending. And, it is quite overwhelming. Many hospitals have a common transplant coordinator for living and deceased, but now bigger hospitals are finding transplant coordinators for different organs and trying to keep a separate one for deceased donation. So really, when it comes to approaching the family, in our country, we do 2 sets of brain death tests. Unlike some countries where brain death testing is done only once, we do it twice. And of course, death is declared after the 2nd test of brain death. But counselors start speaking to the families after the 1st set of tests. And of course, we follow this approach of decoupling, where the news of giving death is done differently and is very different from the conversation where you are having about organ donation. Most hospitals do not have a designated place for this kind of a conversation. And of course, bigger transplant centers are now finding rooms which are designated for conversations on on organ donation. But especially in government hospitals, there are very often our transplant coordinators are literally standing in the corridors and talking to families. Sometimes that's how sad it is. And who does the conversation? So in our training, we are strongly advocating an approach where we feel the treating team, after having given the news of death, should also be part of the conversation where they're talking about organ donation. It is something that we learned with our association with NHSBT. In fact, we have created a film based on a film that was made by NHSBT. And we think that's a better approach. But to be very honest, in practice, once the doctors have spoken to the family about death and medical issues, they usually move back. And there are very few hospitals where they come back together as a team with the transplant coordinator to speak to the family. So usually it's the transplant coordinator speaking to the next to the kin. We encourage we encourage the transplant coordinators to at all points remember that it is the family's prerogative. It is ultimately their decision, and that should reflect in both your verbal and non-verbal communication, and not to lose sight of the fact, despite the tremendous pressure that sometimes hospitals and managements put on donors. Slightly more complex in our context because we are large families, we are extended families. Usually when there's a death in the hospital, you will sometimes have 30 people standing outside, and it's sometimes very difficult to even understand who the near relatives are. And it's important for our transplant coordinators to understand there could be a spouse, but perhaps that person is not the decision maker. It could be someone, some relative in the family who's kind of respected and who's looked up to for decision making. Very often it is the villagers, the panchayat heads who are deciding on behalf of the family. So it's important for transplant coordinators to assess these families. Who are the close relatives? Who are the decision? What are their relationship? Socioeconomic status comes into play. Very often poorer families are coming because it's an emergency case. They want to come to a bigger hospital and they not necessarily can afford the if many of you will know, most of our health sector is in the private sector and it's expensive, it's unaffordable. So there is chances that the family will bring up money issues. So for families to understand that and be ready for that, understanding religious orientation. We are a country of multiple religions, and understanding what is this family likely to say about it, and has the family really understood the condition. Very often you will have illiterate people from rural areas, have they really understood what the doctors are saying? So we encourage the transplant coordinators to build a partnership with this family, and they're taught to ask open-ended questions, which usually begin with something like this, so to establish that the family has understood death, because we don't want to fall in a pit hole where we start talking about donation where the family is not even really understood brain death, because this is a subject that's not very well understood in our country. Again, obtaining consent as per the act. If it's a married person, the spouse has to give consent. If it's a minor, the parents have to give consent. It could be the older children if it's a. But what we actively encourage is that make sure that the family is all aligned, that there is no dissent within the family. It is a fairly new program in our country. There is still a lot of stigma around organ donation. There is fear around organ donation. So we want families to feel happy with these decisions. We do not want organ donation to create dissent amongst families. So that's some of the work that they do, apart from the fact that they have to coordinate with recipient, other hospitals, organizing green corridors, involving the National Agency for Organ Allocation and all of that. And we encourage them to do public awareness, with help with research, of course, maintaining records and documentation of all the cases that they do. Why are some of the reasons why families say no? It continues to be the biggest reason is a lack of understanding, a lack of, a conversation around organ donation. Most people haven't even heard about organ donation. They may have heard about eye donation, but for people from smaller towns and rural areas have really not even fathomed that there's something like a multiple organ donation. So that's one of the bigger reasons why families say no. Many of them are waiting for a miracle. Their religious intimidation, very rightly, fear of mutilation. One of the biggest reasons families say no is a strong distrust in the medical community, the private hospitals. Families think, oh, I lost my loved one, this is a huge bill, and now they're trying to make money out of the organs. So it is quite a task for our transplant coordinators to go past that challenge. And of course, events in the hospital during treatment, how involved the treating team was and how communicative the treating team was. So as Mohan Foundation, we have the luxury of seeing different hospitals, and we see why certain hospitals do better in organ donation is because the treating team is very involved with the families right from the beginning. And it's important for transplant coordinators to understand that every no is not about them. It's not their failure. There's a fair amount of pressure from hospitals, and from transplant teams every time a brain death is declared to turn it into a yes. So we keep reinforcing it for the transplant coordinators that continue to show support to the family, and remember that it was not about you. It was this family with its own unique experiences, with its understanding of organ donation, and with their experience with this hospital that made them say yes or no. And that's a very favorite picture of mine. I just don't seem to get a better resolution for it. But that's how typically our transplant coordinators feel in our country. They're not very empowered, sadly. So, these are the on the right-hand side are the transplant teams and the hospital management and the ICU teams. Very often it's very scary for transplant coordinators. But I tell them, you are an important person, and please walk tall and be proud of what you do. Doing great work. Thank you so much.
Oh, thank you very much. That was absolutely fantastic from all three. So 3 really, really good presentations. And I think what's always fascinates me is actually, around the world, there's so many similarities to the programs we run and so many common themes. And even Pallavi, you were talking about why families say no, some commonalities with what we hear and what our data here in the UK. So really fascinating to hear from all 3 presentations. Thank you very much. I think there are 1 or 2 questions in the chat. I'll do the first and then hand over to you, Alison. And then the first question is, do donor nurses come to organ donation from a particular practice or background? And can they come to donation immediately upon qualification, or is a certain amount of experience? I can answer that from a UK perspective. And what I would say is that historically, the majority of our coordinators came from an ED, emergency department, or an intensive care background. But now, because of actually, we want to get the different experiences, and because actually the shortage of nurses UK-wide, we are beginning to open up the pool also because of the different roles that we have available here in the UK from a donor coordinator perspective and a specialist requester perspective. So it's not all A&E and not all ICU. We would encourage people, we actively encourage people that are involved in end-of-life care, palliative care roles to actually come and join us. In terms of education and training, what I would say is we would encourage people to get some experience, you know, a couple of years under their belt first before they come into this really exciting speciality, because it's really good to have some clinical experience and clinical knowledge coming into the role. So that's from the UK perspective. Alison, I don't know whether you wanted to add from Australia, or any of the speakers want to add in from their areas.
Yoni, did you want to comment from Australia, or would you like me to comment?
I'm happy for you to comment on that one. Yeah.
Look, I think, you know, we're probably very similar to you, Olive, in the UK, where most of our donor coordinators, and there was a question in the chat from Dale about donor coordinators and transplant coordinators nursing background, and most definitely that, you know, in Australia, all of those coordinator roles really are from a nursing background. So donor coordinators in specifics are that emergency department and intensive care background, although I have seen in some of the states and territories that they have actually opened it up to get those different skill sets in, like utilising nurses from operating theatres coming in, because they bring a really different perspective into that retrieval component of the work that we do here as donor coordinators in Australia. But from a transplant coordinator perspective, a lot of them have come through working on the wards that specialise in those areas, for whether it's, you know, liver transplant or coming through from dialysis management or those sorts of things. So I think there's a wider scope within this sector. It's not just about focusing on our donor coordinators. There are other roles that can absolutely take part that have different skill sets. And I'd also agree, because of the nature of the work that we do and the challenges that we meet, we do recommend that they have at least sort of 3 to 5 years of experience as nursing before they come into this role, because it brings with them that clinical expertise. It also brings with them an understanding of what patients require and what families require. And it also gives them an understanding of how to manage all those different stakeholders that we have to manage as donor coordinators across theatres and medical staff and, you know, different other nursing groups. So I think that's all really important to that role as well. Yoni, did you have anything to add from an Australian perspective?
No, I totally agree with that. Yeah, there are lots of hurdles in this role, and I think it does, for us, for the most part, donor specialist nurses come from an intensive care background, and they are all nursing positions. And I think that helps to embed us into the nursing culture that we have in our intensive care units. We're used to end-of-life conversations. I think end-of-life conversations for an intensive care nurse, you know, that's probably 20% of our patients will follow an end-of-life pathway. So for us, it's a natural, this is almost like a critical care nursing specialty. Yeah.
Pallavi?
So we have a mixed, while there are some coordinators with a nursing background, but we also have a lot from social work background or sociology background. Nurses per se in our country, again, are not very empowered. You know? So a lot of them also come from areas where language is a problem. You know, they've come from the lower part of the country and sometimes do not speak in a language that could be of help in other parts of the country. I do think coordinators with a nursing background do have an edge on you know, but right now it's still not a very developed the field. The transplant coordinators as such are not, it's not a very developed field in our country, and I think, yeah. like the act said, it could be someone with a nursing background, or it could also be someone with a master's in psychology, sociology, social work. So it's a mix. It's background.
Excellent. So different practice across different places.
Yeah.
So I might just pop on to the other question. And I guess both Jill and Yoni, you both really spoke about being involved in those really early end of life conversations and being embedded as part of that end of life. And that being a crucial part of the donor coordinator role. So there is a question here about, how has this been approached? That embedding in the end of life conversations, because the person who's popped it up there anonymously says that sometimes they really struggle to be involved in those conversations.
Is that to me?
You and Yoni, both of you want to take a turn?
I would say in Australia, we approach that carefully with subtlety, because you're right. There are people that are really uncomfortable having a donor coordinator in the room in an end of life conversation, and I think that's the whole reason that we want to be in every conversation, because it just needs to be part of end of life care. It needs to be that we feel that we're not asking for organ donation, we're offering organ donation as a part of good end of life care, just like we would say, does your dad need to see someone from his church? It needs to be that we feel as comfortable saying that as, have you ever, if dad was sitting here today, how would he feel about organ donation? Those sorts of things shouldn't be difficult. They should just be a part of the care that we offer. And I think for us, the way that we're trying to really embed that is by having value add in our intensive care departments. So whether we get or for me, whether I get a decline or a consent to donation, I would stick around and help the nursing staff with the end of life care of that patient if they needed assistance and if the family needed further support. So we don't just get a no and walk away. It's just that they have declined that offer of donation. So I think that there are subtle ways that we can become embedded. Is it easy? No, I agree with that statement. Sometimes it can be very complicated.
Jill?
Yeah, thank you. I've written a few notes down here. I think this is part of what I was saying about the embedded role. Being in the hospital makes you omnipresent, and that's what we've worked on coming back after COVID, is having that presence, having that visibility on the units so that people know that we're there, and have that confidence and trust building that we bring to the team, so that clinicians particularly, who are usually the gatekeepers to those conversations, feel confident in bringing us into the conversation because they know us. Where that also comes in is with my role in medical education training, that yes, I'm ingrained in the education team, but with my particular role, I work alongside the clinicians to work on these sorts of issues, to build confidence with trainees coming through who are going to be our next generation of consultants, so they have confidence that this is actually a really good thing. And we run courses throughout the year with simulation so that they get practice at doing this, and that they get a real immersive feel for how that would feel for them and what the benefits of using a specialist nurse would be. So that's a few things there. But one of the things that really worked for us by default was the legislation change. So we moved from a system of opting in to a system of opting out recently. And with the training that we had delivered to the specialist nurses, it actually started a ball rolling really about what was happening with those conversations. And we really dug down deep into what was happening about planning, about arrival at the hospital. How could we manage that? So all of that really became a real big focus for us, and how we can do that much more effectively. And we built that into our training that we do for the medical people, built that into our training for the specialist nurses, so that everybody's now, it's a cultural change about looking at the best point to bring in the specialist nurse. And certainly Dale, does a brilliant job with the medics to give them that confidence that, you know, this is a really worthwhile investment. And being in the room early on when families are making those very tentative thoughts around donation, you know, they may have some questions, and certainly with the legislation change that families were asking earlier and needed their questions answering earlier. So it's been a real tipping point for us to be able to get into the room and advocate for doing that much earlier.
Yeah. And Pallavi, I could see you nodding along to some of Yoni comments there. You know, did you have some comments around
that resonated
vetting?
with me, because that's what we tell our coordinators, that, you know, it is about giving an option to the family. It's actually a privilege. You know, not every family has a brain death, and not every family has the privilege of having this additional option of. So, you know, how coordinators have to relook at the ask itself is something. And it's a little sad sometimes in our country, because our system is very different from UK. And an organ means the transplant for the hospital, it's additional money for the hospital, and sometimes that pressure comes in, and sometimes that might color the conversation, or at least the approach that coordinators have. And I think in that sense, people like me who represent an NGO, who not necessarily representing a hospital, have a slight edge, because we are there purely for the passion of making this happen, you know, purely for the passion of giving this family this option, this unique privilege of taking this option of whether they want to donate their loved ones' organs and save lives, and, you know, and not just because you're part of a system that needs to make that donation happen for a transplant. So we have our own challenges, which are pretty unique to our country. But yeah, so when Jill said, you know, we are embedded in the system, and sometimes that's an advantage. In our case, sometimes that could become, you know, a pressure, a disadvantage, or sometimes. Yeah.
It's quite interesting. There's a comment from one of our participants from Singapore saying that their coordinators are not nurses, that they're mainly life science or science graduates, that it's not a favoured job for nurses, which is...
That's fascinating in itself, isn't it? As Dale has put in the chat. Yeah, that's really fascinating. Yeah, really, really good discussion on embedding end-of-life care discussions. Our next question is actually a really, really important question, because we've all alluded to how important these conversations are. And for donor coordinators around the world, it is an absolute privilege to be involved in these discussions with families. You know, it's such an important element of end-of-life care, and a real privilege for us as healthcare professionals to be involved. And the question comes from somebody in the audience asking about, how do you coordinate donor family follow-up and care where you work? Yoni, I'll come to you. I'll go to Australia. How do you in Australia look after families post-donation? What's your follow-up?
So we do immediate follow-up. It depends on whether a family is going to do a viewing of the patient straight after we've done the retrieval surgery. So at my hospital, if the family want to see the patient after retrieval surgery, I would dress the patient and make them look beautiful and take them back to our intensive care unit where the family have been and where the staff have been that have supported them. And I would tell them there and then what we had been able to retrieve. For some families, they don't want to see the patient after theatre, and I negotiate a time to call them straight away after theatre, or, you know, in 24 hours at a time to suit them, and update them sort of immediately. And I check in on them at that time as well. And then again, that little bit of separation between us and transplant, our state donor coordinators will get an update from the transplant teams as to how those recipients are going. And I will also talk to the family as we're coming to sort of the end of the donation about when I will follow up with them and let them know how the recipients are going. And it's very de-identified information. And it's normally for me about 5 days after donation. And I will call the family then and give them that update. And they often like that for their funeral service as something to tell people like who they've helped. It's very de-identified, but it's a beautiful phone call because it's what they're wanting to hear. But for me, that's a nice closure to my follow-up of that case, and it's then handed over. I do a bit of a check-in as well with the family there and sort of talk to them about whether they have any questions, if there's any further support that I can provide to them. And then we actually have family donation support. We have family support staff who look after the families from that point on as well, and they will make a call to the family. They organise a letter of gratitude from our service to the family with a further update. And some of our families have an ongoing relationship with those coordinators for many years. They will ring up and request to hear how the recipients are going, and they will facilitate that for them as long as that family needs. So it's an ongoing, for our service, that relationship with the donor family, that extends as long really as the donor family wants it to. That's the focus.
It's fantastic, Yoni. Very similar to what we do here in the UK. Your family support staff, are they clinical or non-clinical staff?
So a little bit of a mixture. So some of our staff are social work background. Some of them are donation specialist nurses that have just really have that passion, for the family care aspect of our role, and they will transition across and into that role. So it's a bit of a mixture, but it's not only nurses. So some of the staff are social worker background.
Fabulous. In the interest, I could talk about this for all day, but in the interest of time, I'll go to Pallavi and just ask, is anything different you do in India, or what's your current practice?
So it again becomes dependent on that particular coordinator. So we don't have a specialized staff that does donor follow-up. It is the coordinator, and it is the coordinator's independent motivation and passion that will allow or not let her do a donor follow-up. But if I speak on my experience, of course, all that Yoni said, and then we will visit the family for their prayer meeting, which is usually on the 4th day or the 10th day. We hand over a certificate, we visit them at their place. And depending upon families and their willingness to engage, there are some families who want to be more in touch. There are some families who like to be kind of left alone. There are some families who are regular participants at our online program for organ donor ambassadors. We have a training program for people who want to become ambassadors for organ donor, and then we have it's an online course, but there is a scope for interaction, and we bring in donor families or recipients, and there is an interaction there. So really, I mean, I had gone to the US a couple of years ago, and I saw how OPOs do these donor memorials for donors in that area. I wish we had something like that, because really it gets left to individual hospitals and individual coordinators. Some of them are more motivated and put more effort in it, and some of them just really do nothing beyond a donation. So yeah.
Thank you so much. I'll just come to Jill in the UK. Just in the interest of time, Jill, is there anything else different that you wanted to highlight from UK practice?
No, I mean, traditionally we had a very personalised follow-up service with our families, but that's had to move now because we're so busy. We can't do that so much. But there are opportunities that we have if through the regions, in that plenty of regions have family services, remembrance services, and the St John's Award that we give to families to honour their gift. It's a chance for specialist nurses to re-meet their families, which is really important to the specialist nurses, and that often feeds through to families who keep connected as you experience, and contribute to our ambassador programme as well.
Thank you, Jill. I'm going to hand over to my co-pilot, Alison, just to say the final words. Thanks, Alison.
So we're 1 minute out, so I think we've timed this very well. And just to, end it off, there were a couple of comments in our chat there, and it was about donor coordinators being expert diplomats and skilled at negotiation. And I think there's some key words for what donor coordinators are in this space. So, I thank you all for joining us for this Commonwealth Tribute to Life webinar. And for all to our speakers for contributing and discussing their knowledge and information on donor coordinators. And I'd like to remind everyone about next week's webinar on Tuesday, the 24th of May. This webinar will be on honouring deceased donors with insights from speakers in the UK, Australia, India, Canada and the South Africa. And it's going to be a special 90-minute edition, so I strongly recommend you attend if you can. So thank you to everyone, and good night or good morning wherever you may be.
Thank you so much, Alison.
Thank you very much.
Jill.
Thank you all.
Bye-bye.
Thank you for joining.